Hey, good afternoon and welcome. My name's Andy Bleed and I work for the ECH Alliance Global Health Connector. We're pleased to be partnering today with one of our members, the World Federation for Incontinent Patients and people with pelvic flaws, taking place during Continence Week to bring one of our thematic ecosystems, targeting continence and mental health in particular today. We're going to be recording this and then serving it up as well for the rest of the week for other people as part of an ongoing series of global events around continence that's taken part this week, creating content for further participation later. I'm pleased to say we brought in colleagues from across the globe, and hopefully all our speakers will be here to tell you more about what they do and where they do it. I'm also going to hear from the WFIPP as well, with a message from Mary Lynn as well. But what I would like to be able to do, whilst people are just coming in, is just explain a little bit about us. If you don't know who we are, we're the ECH Alliance, we're a global health connector. We have been around for about 14 years, bringing people together, a network of over 1,100 organizations, and we bring those organizations together in a network of ecosystems. So as a member organization, we do what a lot of member organizations do, but completely focus in the world of health and digital health. We connect people together, we convene people together in ecosystem sessions like this, both in person and online. We also amplify what our members do, and we'll be hearing from some of our members today to see where they can better collaborate, because we work in a world of digital health where people work in silos. And lastly, we also accelerate what our members do. Now, we've been around for, as I said, for around 14 years. We've built a network of what we call ecosystems. These are permanent multi-stakeholder gatherings, bringing together all the players of health, as you can see in front of you. Matching need and solution. We do this because we see silos in health that are very large. So these ecosystems are there to break down some of those silos. And as you'll see today, hear from both need side, but also a solution side from best in show, in terms of best practice, learning, knowledge exchange, but also development of new and exciting digital solutions. And you'll hear from one of those today. We also use these to actually do stuff, okay? Because it's okay to talk about doing stuff, but we use our ecosystems to get on and do things. So to find ways in which we can collaborate better. And then lastly, we use our ecosystems to try and enable economic growth, because there is a place for both public and private in these ecosystems to be able to try to find ways in which people can develop new innovative solutions and ideas and actually get them to market. Because we see again in healthcare a dearth of implemented digital health solutions, as people usually want to look for further pilots and put delays on adoption of really good practice. What we've done with that concept of ecosystems is build a large network, which is global. So you'll see here some of the ecosystems we have around the globe, whether that's in places such as Argentina, Zimbabwe, we've just opened up in Switzerland, also in Turkey and Singapore, as well as Los Angeles. What that means is we're better able to cast that net wider to say, okay, what does good look like in, say, Denmark or in Romania, as much as perhaps where we would traditionally look very often in healthcare. There's always been a bias towards either the US or Western Europe. And that network we've built is based around collaboration. So those ecosystems, collaborate together, they work on projects together, they share best practice, but they also collaborate using a series of what we call thematic ecosystems, which are virtual. These have the same process, the same ideas around matching need and solution, but on different topics. So we're able to better bring in different opinions, different ideas, different thought leadership, but also different areas of collaboration from across the globe. One of those is one we've been proud to partner with WFIPP on, which is targeting continence. So we're going to see a message or a video now, short message from Mary Lynn, who's unfortunately not able to attend today. And then we're going to ask one of our speakers, Lucy Brett, to talk about her understanding and her experience within this area. So we're going to share a video now, and then Lucy, we're going to come to you now next, and you can share your screen, please.
You want me to go with sharing my screen?
Yeah.
Yes, you may be. I'm very pleased to be able to join today. You may be. Good morning, everyone, or good afternoon, wherever you may be. I'm very pleased to be able to join today for this, our third webinar in the World Continence Week 24 series of webinars. Very exciting, in fact, because what we're noticing is that World Continence Week is gathering momentum year on year. And in fact, we're inundated with requests and all types of events that are taking place this week. So it means that incontinence and raising awareness is truly on the global roadmap. In fact, yesterday we had our second webinar, which was dealing with, let's call it the cultural divide, cultural issues, and that ranged from Latin America, North America, Europe, and the Middle East. So we will make sure that all the webinars are there on demand for everyone to view at your leisure, but I do recommend that you do watch them. For myself, as president of WFIPP, what I notice is that there is a focus, especially now that we're talking about the ecosystem and incontinence, on mental health issues. This is high on the EU agenda, and we will see what transpires in the coming sessions with the policymakers in Brussels. But there is a very big, how should I say, affinity with mental health and incontinence, the feelings of loneliness, the feelings of depression, both in male and female. And I'm very pleased that we've actually managed to bring together some excellent speakers today from the various communities, industry, patient organizations, research, and of course, we have the Alliance who are kindly hosting this webinar. So I will stop there and really wish you an excellent webinar today. And I'm very interesting to hear what the various speakers have to say. And thank you to Andy for your help in hosting today's webinar. Thank you so much. Bye-bye.
Thank you for that. Lucy, sorry about the clunky gears there. Over to you.
Hello, sorry about that. Hi, thank you so much for having me here. My name's Lucy Brett, or Luce Brett. I don't mind what people call me because I'm one of 4 children, so I'll answer to pretty much anything. And I'm here to give a patient's perspective. Now, is it? There you go. I'm an author, I'm a continence patient, and I have been for, I mean, I would say I'm not sure how long, but my son turns 17 in about 3 weeks, and that would give us a pretty good start date for when my continence and incontinence journey really began, although perhaps it began when I was being potty trained, but that's another discussion. I'm an author, I'm a patient, I'm a lay advisor, I do voluntary work for the NHS, especially around system change. And I'm an activist and teacher. I also teach people about medical memoir and the importance of finding patient voice, whether that's for you personally or in terms of wider advocacy and making change happen. My first non-fiction book, PMSL, was published a couple of years ago. it was written, it's a medical memoir, but it's not just a piss and tell or a tell-all story of me, although it does go into a lot of detail and frankness, but it was also designed to be a calling card and to start a conversation around the realities of incontinence, the ease with which sometimes it's spoken about, as well as conversely, the difficulties people have to talk about it. And I'll come onto that in a minute, because I think that's one of the really big problems with a lot of policy discussions, is that people want to talk about things clearly, but therefore they forget that incontinence is an intensely personal and sometimes devastating condition. The tenet of the book is that your pelvic floor does far more than hold a few of your organs in place, whether you're male or female. It keeps your whole life together. And my book is about when my life fell apart because my pelvic floor failed. I also wrote it for practitioners, not for practitioners to give them a bashing, like some medical memoirs, but because I wanted to go through in detail what it was like to be a patient. And it's quite forensic in its exploration of the impacts, both of mine and my attitudes and other people's attitudes, and also of healthcare professionals. So that's a quote from Myra Robson, who runs the organisation Pelvic Raw and the Squeezy app in the UK. So she does a lot of work in incontinence, and she said it was the best book she'd ever read on to inform her practice. So I was asked this week to talk about incontinence and mental health. There are chapters on depression and anxiety and survival in my book, but I thought, incontinence has been a long old journey for me and it's still ongoing. So I thought I'd jump forward to Tuesday when I couldn't do one of the talks for WC World Continence Week because it was my birthday. Happy birthday, me. And because I had to spend the morning in the bowel management clinic being introduced to transanal irrigation and looking at the techniques used for that. I was told that this might help my incontinence and it may help me empty myself properly and give me 1 to 2 hours during my worst times where I could potentially leave the house knowing I'm unlikely to leak. Throughout the entire experience, I was treated with kindness, respect, I was shown compassion, I was asked my consent multiple times. And yet, if we take a step back, what do we think the impact of that brief, hour-long interaction had on my mental health? I'll highlight just that bit. It may give me 1 to 2 hours where I can go out. I'm 47. Also, does that look like the sort of birthday present you would like to receive? Not me. But that is, it may give me the gift of freedom. I'm not knocking technological advice, but I was told I may get a couple of hours a day. And I think, well, we know that bladder and bowel problems can lead to feelings of isolation, to loneliness, to depression, and that incontinence can lead to a lower quality of life, and that there are little discussed emotional side effects of it. We know, now of course, lots of the figures have to be aggregated and there are cultural differences, there are different prevalences, but also very different ways of talking about incontinence. The research is not always like for like, but we know that with severe incontinence in women, the chances of depression are much, much higher than those with even mild to moderate degrees of incontinence, and that incontinence can lead to depression. We know that anxiety is over 50% higher in both men and women when it can cause impaired function, and that when incontinence is so severe it impairs your functions. More broadly, that the prevalence of anxiety is absolutely massive. So we are talking about really quite a lot of the continence patients that people see, and we're talking about quite a lot of people when we look at the stats about incontinence, because it affects similar numbers to people who have hay fever. So happy birthday to me. It's also worth noting, so I've glossed over it, and it's kind of a superpower. It's how I wrote a book. I've glossed over fecal incontinence, but this is a quote from a report on News Medical Net, but there are lots and lots of quotes that are similar, that fecal incontinence in particular, that's losing control of your bowels, has much, much higher rates of depression and anxiety, alongside feelings of humiliation, desperation, and social ostracism. And this is primarily related to the fear of it in public. I mean, I can concur that these things are terrible and very upsetting. And that's why I highlighted the phrase, you know, you can have 1 or 2 hours, because that is not very much. That is not very much time to not be in this kind of state. Now, we know, and World Continence Week, I have to say, has done an incredible job this year in highlighting particularly loneliness as a result of incontinence, because I'm here talking to all of you today, but frankly, it is not so easy to do it over a workplace Zoom, or to explain to my bosses where I was on Thursday, or to indeed tell people who came over for dinner at my house that evening where I'd been. But there's a bigger story here. Incontinence does cause loneliness. And we know that loneliness is potentially lethal. We know loneliness is a killer. We know people who are isolated and lonely are more likely to die prematurely than those with healthy social relationships. So with incontinence, its link to mental health is also a catastrophic link to poor health outcomes completely, to premature death, to absolute isolation. And I don't say that to be grandstanding. I say it because that's what I mean. Sometimes something that's hard to talk about can become a little bit too easy to talk about too. And I think that that's really what happens with loneliness and mental health sometimes. I got this from medicine, I've got all the links at the end, so you'll see them at the end. But this is a quite common responses to incontinence include denial, anxiety, frustration, and anger, grief, and depression. Well, I know this because I tried to structure my biography, PIMSL, alongside the stages of grief, but I found that they were too repetitive, because every appointment can include all of those things. So can every conversation you have about your condition. Every time something gets worse because you're aging, if you're female, because you're going through the menopause. All these things can make these terrible side effects of incontinence, which are nothing, you know, and I'm not also, you know, we also don't talk about adult nappy rash or urine burns or multiple infections, not just in your genitalia, but everywhere else because of incontinence issues. But these are really big deals. As I said, I nearly structured the whole book on that. I think that the other thing I wanted to bring up was that depression, and this is urinary incontinence, but I would argue also the others, have an additive effect on each other. The worse your depression is, the worse your incontinence is. The worse your continence is, the worse your depression is. I'm going to read you a tiny extract and then I'm just about done, but I just wanted to give an idea of the sort of way that I used writing to explore this. So, urge incontinence, for example, brings home the silence to me more strongly than anything else, perhaps, in my incontinence journey. And perhaps that's because psychological and physical symptoms and sensations are so entwined. Your panic and anxiety does set off your leaking, but you have to move beyond seeing the whole shebang as a personal failure. Also, the treatment can involve not running to the toilet or actually giving into your, Also, the treatment can involve not running to the toilet or giving into fear, and consequently can be very messy and antisocial at first. But it would have felt easier, better even, if I'd met just someone else who'd been through it. If I'd met someone who could say, the treatment's hardcore, but it worked for me. If I'd had someone to swap thoughts with on laying out multiple outfits at the start of each day or getting adult piss out of a carpet. Retraining your bowels or bladder is a brilliant mixture of humiliation and hope. I soldiered on, I improved, the Kegels toned my pelvic floor. I learnt to live in a no woman's land of just continent enough, with only occasional accidents. I also learnt a lot about urinary tract infections, which antibiotics give you thrush, and what time of day the GP needs a sample by. Throughout this experience, I try to be grown up, but there is a gnawing sense of something, probably disgust or despair, that in trying to fix my continence, I have wound up in a land of leaked on pants and clothes. I am permanently on the edge of being unhygienic. This is a problem because personally it's devastating, but it's also should have an economic and political imperative. With rapidly aging populations, the impact on mental health of growing continence problems and bladder and bowel health issues, which come often with aging, is potentially catastrophic. And I think that we do need to talk about it in those terms and think very carefully about what we can do. Obviously, what my extract showed is that I think that there is a great deal that can be done in advocacy, storytelling, whether it's telling yourself, writing a book, telling other people. But I think that that is known to work with mental health, and I think it probably would help with incontinence if it was done more widely, and that bringing the two together could be incredibly powerful. However, I'm just a patient. So I say to everyone on World Continence Week, good luck, get in touch. If you want to talk, I'm really happy to help out in any way I can. And PMSL is available in print, on Kindle, on audiobook. I would love to hear from any of you. And those are my references in case you wanted to know where I got my evidence. Thank you very much.
That was very, very powerful. Thanks for that. And I think what you talked about there in terms of the potential for both talking and sharing, but also hope, is something we'd like to be able to amplify. So we'll make sure we can put some links in as and when we send out the videos for book number 1, 2, some of those references you talked about, but also, if that's okay with you, your contact details there, to get people to reach out to you. As well, because that's a message I know, certainly from the work I've done in mental health, that's important when there's other people to be able to talk and share and understand and say, that's what I have, that's where I'm suffering or missing out in terms of support. So,
almost everybody who's contacted me since I wrote the book has said something along the lines of, I have never told anybody this, but, and I'm talking senior doctors, famous people, my friends' parents, all sorts of people. And they all said the same thing. They said, when I read your book, I finally thought, yes, somebody else has done that. And I've been keeping this quiet for 10, 20, 50 years, so it's an area that's ripe for help, and it completely dovetails with continence's impact on mental health.
So, as part of this ecosystem that we're bringing together, looking at continence and mental health, we thought it's important not only to hear the voice of patients, and we've heard already from them, and industry, but also to bring in the voice of health professionals. So what I'd like to do now is introduce Dr. Miri Marad, who's a member of the International Neurological Society, who's going to give us an international view, but not from Europe or from the US, but from the Middle East, Iran, and what's happening in some of the Arab states around continence, because obviously we've got very much a westernized view so far. This, I think, will help give a different flavor, because again, as the global health connector, that's what we like to better do.
Hello everybody, my name is Dr. Mehri Mehrad. I'm consultant urologist and the board member of International Neurourology Society. Today I'm really grateful joining to Urinary Incontinence Week webinar with WFIPP, and I am really grateful that I joined to this expert team of incontinency and the president of WFIPP, dear Marilyn. We want to talk about the thematic innovation of urinary incontinence. And actually, as a doctor that I am working in Middle East countries, I'm Iranian working in Tehran basically, and also in Arabic country, and this is a concept of urinary incontinence in this area because of culture, because of taboos, and some religious and cultural stigma and taboo. The management is completely different. Based the incidence of urinary incontinence, that 30% of people in the world, they are suffering from urinary incontinence. So the high incidence of urinary incontinence is a matter because the ladies, they cannot be socializing because of urinary incontinence. Even they are always worried in socializing, in walking or in jumping time or in activity time, also in traveling. The people, the ladies or the men that they are suffering from overactive bladder or urge incontinence, they cannot travel by car because they have urge to void. They need to go to bathroom every like 30 minutes. So that's really affect to the social activity of urinary incontinence patients and affected people. Urinary incontinence is a disaster for some people that they are completely obsessive about the cleaning or something in these countries, in Arabic countries or our country, because leakage of urine is not a normal problem in this area, because with urinary leakage they cannot go to praying, they cannot feel clean. So not only urinary incontinence is a ecosystem problem because of the huge budget, huge cost for treatment, for prevention, or a huge problem that they are facing it with that. And not only because of that, also because of this area, in our area, because of the cultural and religious taboos and beliefs is twice or triple times more problematic for patients. As you know, urinary incontinence is 30% incidence in the whole world for male or female. Of course, urinary incontinence in males is more problematic because they don't use pad as always, so they are suffering more in silence. And also for ladies, because in our area, the ladies, they like to go to female doctors, and because of a few female urologists in this area, many female patients, they are suffering from urinary incontinence. They don't go to doctor, and they have problem and they are suffering in silence. Actually, the awareness of prostate cancer is a huge information, is huge awareness, and the policy of acknowledge about the prostate cancer is highly spread in every country, all doctors. But urinary incontinence is not like prostate cancer. Imagine in all small cities, in all small countries, even a small province, all GP doctors, they know about the prostate cancer, they know about the management, so they are doing based algorithm for treatment for prevention of for prostate cancer. But for urinary incontinence, we are responsible, even especially in this urinary incontinence week, we are responsible for giving information not only for patients, for healthcare providers, for doctors, for GP doctors, for giving them algorithm, giving them information about the prevention and about the management, about the different kinds of urinary incontinence. And also we are responsible for giving this information to patients, that if you have urinary leakage is a matter, it's not normal, because many gynecologists, they are telling to patients, okay, it's normal, don't worry, it's not, they don't consider about it. But our responsibility in this urinary incontinence week is giving information to healthcare providers, to societies, to patients about urinary incontinence. Regarding Urinary Incontinence Week and all activities that WFIPP they are doing in this week for giving information and raising the science in this matter, it affects really to the innovation ecosystem and also for incontinence management. As you know, we have a lot of refugees in all European countries. We have around 2 billion Muslims in all countries, in European and in the whole the world. And the concept and the management of urinary incontinence in Muslims patients is really important. In this Urinary Incontinence Week, as a member of WFIPP, and in this grateful webinar, I want to emphasize that we need culturalized questionnaire for all religions, for all different cultures, and we should establish a committee for diversity, for covering all different community, different cultures, and different religions, because the management of urinary incontinence, as based my experience from 15 years ago that I'm working on voiding dysfunction and urinary incontinence, country to country, person to person is really different. So urinary incontinence is not only, in my opinion, 30% in our area. Many patients, they have urinary leakage after delivery, after pregnancy, and they are doing many another options, another treatments, even home remedies for prevention of that. But for long term, after they are referring to us, they have urinary incontinence, they are saying from 10 years ago or from 5 years ago, and all years they were using daily pad for controlling themselves, for prevention of, tears comes to the leg. So the cost of using pads, using Easy Life, and the recurrent UTI because of urinary incontinence has a huge cost, has a huge suffering and pain for patients, and also has a huge effect on the community and their activity in the community, in the society. So I'm really thankful for WFIPP and dear Marilyn for starting this international movement for giving information and acknowledge about the urinary incontinence to people. And as a member of WFIPP, I would like to have some webinar with people, with patients from different countries for understanding about the diversity and different concepts of urinary incontinence. And thank you.
Thank you for that. Thanks for that. So what I'd like to better do now, if people have got Q&A questions and answers, there's a little box at the bottom of your screen, which I haven't got my glasses on, but I'm sure it's down there somewhere. But it's usually down at the bottom, or if you've got one of these fancy computers, it might be on the top. Now then, please leave any Q&As in there in between now and the end of this recording. But what I'd like to do now is turn our attention to the other half of what we talked about. So we talked about a need and we talked about some solutions. So I wanted to introduce John Kelly, who's based in the US, but works for one of our members called Connected Health. Very similar to how our name, but very, very different, completely separate than our organization. Not linked at all. So there's no sort of, it's not our own brand products, but Connected Health have been doing some, I think, pretty revolutionary work, not just in terms of digital health products, but specifically in the area of continence. I'm not going to say anything else. That's John's job. John, introduce yourself and let us know about Airception.
Thank you, Andy. And thank you to the European Connected Health Alliance and the World Federation of Incontinence and Pelvic Problems for organising this webinar today. And Lucy, thank you too for sharing your presentation so openly. As Andy mentioned, I'm John Kelly, and I don't want to spend too much time talking about myself, but I'll quickly let you know that I've spent the last 15 to 20 years within healthcare and life sciences, most of which has been in the remit of industrial research and product development. And we have a little bit of trivia. I'm also the founder and inventor of the Airception technology, the product that I'll be going through with you today. Airception is something that we're very excited about, not just because it's cutting edge, though more so it's because we're confident it's going to transform the landscape of incontinence care as we move forward. And it'll do that because it's a world's first solution that detects incontinence in real time through advanced ambient monitoring. So quite powerful. Over the next 8 or 9 minutes, we'll be touching on the problem of incontinence, certainly from our vantage point, that's incontinence sufferers that require some level of monitoring and care, the limitations of the current practices, and then the solution being the Airception product itself. If you look at any of the empirical data, certainly anything from 2021 and beyond, it estimates that 200 million people globally are affected by incontinence. Now that's urinary incontinence. So 45 to 55% of that population will also suffer from severe fecal incontinence. So that's a scary number, and it's not just daunting because of the sheer volume, it's also daunting because of the widespread nature. You'll find incontinence across all spectrums of care, specifically, however, senior care, hospitals, assisted living, and indeed home care. And when we look at those institutes and look at the protocols involved in delivering incontinence care, we can see they're using very dated processes. It's providing ineffective insights, and what it's really doing is actually creating even more work for the nurses and carers involved. And family members too, they're also affected by incontinence. They're not equipped or cut out, don't have the skills or the competencies to know how to effectively manage incontinence. And therefore, then they're often faced with the very difficult decision of having to put their loved one, whether it be a partner, a sibling, in a lot of cases a parent, and having to put that loved one into a permanent level of care, whether it be nursing homes or assisted living facilities. And no one suffers more from incontinence than the dependent themselves, the individual. Incontinence has to be one of the most undignified comorbidities. It also increases the risk of infection, it leads to social isolation, and it compromises underlying health conditions, and not just physical or physiological ones either. Very much to the narrative of this webinar, it also affects mental health. And what I find rather fascinating is that the practices that we use to deal with incontinence today hasn't changed much in the last 50 years, certainly not since the 70s or 80s when scheduled toiling was introduced. And that is the 2 to 4 hour manual checks, depending on what region you are. They're often unnecessary and they're very inconsistent. And they're inconsistent because it's this one size fits all solution. And this blanket approach does not address the diverse individual needs that patients and clients require and very much deserve. And because it's not addressing the individual needs, we then find these delayed detections, these delayed response times. And we know that having this delayed in intervention is certainly not good from any type of health metric, but it's also not good because it's not providing the physicians and the carers with real-time data. Therefore, it's actually compounding the inefficiencies even further. There has been some technologies over the years, albeit very intrusive measures, that have tried to mitigate these challenges. And we're talking things like skin sensors, diaper inserts, and in some instances, even bodily inserts. These are uncomfortable, they invade privacy, and they're very costly to clean, sterilize, or replace after every episode. So therefore, there's not much uptake. And in instances where there is uptake, we have found that there's a lot of stigma and embarrassment associated with their use, we have learned that our patients and clients simply don't want a sensing technology or radio transmitter detected to their skin, certainly not around the groin area. So therefore, then the care providers, they're faced with the only option they have available, and that is revert back to the old traditional manual checks that we know are extremely inefficient and very costly. Now, thankfully and very excitingly, we're confident we have mitigated those challenges and perhaps even eradicated them altogether with the introduction of Erception. And Erception, as I shared on slide 1, is a first of its kind solution that detects incontinence in real time via advanced ambient monitoring. The methodologies around Erception can probably be best described in 4 steps. Step 1, after installing the device, Erception will continuously scan the air surrounding the dependent. In real time, then, it will detect wetting and/or soiling incidences. It takes the data associated with those events and it transmits them to the cloud, where all different types of smart things can start happening. But it also sends that data to web applications for admin and office staff to provide them insights. And importantly, it also takes the data and transmits it to mobile phones. And it would be the mobile phone applications then that the carers would have in hand, letting them know when and where incontinence care is required. Thus, it facilitates this very prompt and well-managed care response. So if we were to look in summary of what Erception's doing, excuse me, it's providing 24/7 ambient incontinence monitoring, the emphasis being on ambient. It's delivering these instant wireless alerts. Thus, it's facilitating this prompt and very well-managed care response. So that's the technological methodologies, as it were. But now let's look at how these features transition into real-life use cases. What I'm going to share with you now are some details around an independently designed and independently managed case study. In this instance, what we did was we took a number of Erception monitors, we installed them into 2 nursing home sites throughout Ireland. The monitors were monitoring doubly incontinent dependents that resided in single rooms. We took the data from that study, we took it directly from our cloud repositories and ran it through a program called Power Analytics BI. And what we started to garner was very promising in that in nursing home 1, Erception detected 90% of events successfully. In nursing home 2, it detected just under 88% of events successfully. And we looked at that data and started analyzing it a little bit further. We identified that Erception monitored dependents spent 6 hours less per day in soiled clothing than they would have if they were relying on, in this instance, would have been a 3-hourly check. So very, very powerful. And I think one participant in this study sums it up very nicely. And where they went on to say, this was one of the users in the study, where they went on to say, Erception was an overall very positive experience. It greatly improved the skin condition of the residents involved. The device was easy to use and very user-friendly, having the mobile phone alerts. They did go on to say that there was a downfall with inconsistent Wi-Fi, though when we investigated that, that was more to do with the infrastructure rather than the device itself, though we didn't want to start editing direct quotes. So whether it be the constant monitoring, the instant alerts, the reduction in time spent in soiled clothing, the improvements in skin integrity, we can start to see the list of benefits what our Erception truly provides, whether it be reducing things like IADs or pressure ulcers and the associated treatment costs, whether it be reducing sequential comorbidities such as UTIs, increasing staff productivity, and so on and so on. So what Erception's actually doing is it's improving health outcomes, it's increasing the efficiencies, while at the same time it's reducing the costs, which is the definition, or at least one thereof, of value-based care. So we're very excited of what Erception's going to do as we start rolling it out with the view to revolutionize incontinence care. And that's just the beginning, because the device itself is packed full of smart technology. We now have embedded AI within our hardware. We have additional sensors, and we've got very clever cloud architecture that lends itself to supervised learning, plurality of learning, all of which can happen autonomously. So meaning the more Erception's used and the greater the adherence to that use, the more powerful it becomes. And in the not so distant future, we'll be opening up some peripheral features such as temperature monitoring, humidity monitoring, even full spectrum health air quality monitoring. So Reception, yes, is going to be detecting incontinence in real time, revolutionizing the approach to that, but it's also going to be enhancing overall patient comfort and well-being further by addressing the broader environmental factors. So very exciting. And we start to look at all the data that we can collate and process from all these features and sensors. Well, it's only going to enhance the analytics and trend insights even further. So yes, we'll be able, and we are detecting incontinence now, but in the not so distant future, we'll also be looking at promoting continence through optimizing toileting schedules and even perhaps leveraging AI to create and deliver enhanced behavioral training and support. So if we actually as we start to wrap up this presentation and ask ourselves why Reception, well, it's enhancing dignity and comfort. As soon as the Reception monitor is installed in a site, it's now a voice for that dependent. It's reducing caregiver burden by letting them know when and where care is required. It's improving the quality of care for the patient's independence. It's reducing the costs in delivering that care. And the data that we're going to derive from is going to also be powerful as well. And my favorite thing about Reception is that it's non-invasive. Therefore, it seamlessly integrates into any care environment and is a very easily maintained solution. So very exciting stuff as we look to the future. I was provided the opportunity to speak here by the European Connected Health Alliance. And I know they have an underlying philosophy, almost a motto, if you will, with respect to bringing people together, exploring for synergies and joining the dots, as they put it. And that's a philosophy that I believe in too, because we can't do these things alone. So if you were interested and would like to know more about Reception, with maybe you're involved in care, you're championing care, and you'd like to know how Reception can benefit your dependents, or look at how Reception can optimize the protocols in your incontinence care delivery programs, please do reach out, because I'm a massive believer that in order to innovate, we must collaborate. And with that, I will just leave you with this last slide, which is very much just a point of contact slide. And that'll give you some sort of measures or some means where you can reach out to us on. And I'll pass you back to Andy. And thank you for your time. Thank you.
Thanks for that, John. Before you go, a lot of people might be looking at this and thinking, oh, that's going to be some bloody great big monstrous things stuck on the side of a wall. What are we looking at in terms of size here? Have you got an example there that you could?
Yes, you still see my screen?
I've worked in care settings for years, and you kind of think,
yeah.
well,
So let me show you. That's one of our demos. And here's my phone, for example. And my phone completely wipes it out. So very small. It's actually under 10 centimeters wide, Andy.
Okay.
Under 10 centimeters wide, and about six centimeters tall. And it's a good point because during our customer exploration work and what have you, dignity is a big thing, and nobody wants this big overly overt device alerting to this, that, and the other. So everything from the color, the oval shape, Reception was designed to be discreet. So yeah.
Thanks for that. I think it's just, I'm conscious, as I said, I've worked in care settings, and some of the things we were sold were great, big, fugly things that were just didn't belong in a care setting at all. Hard to clean, looked horrible. So it's interesting to see the size of that. I'm going to ask if there's any questions from people who are taking part live now. And I'm also going then I think whilst we're waiting to see if there's any Q&As, in terms of the mental health piece, John, is that something that in terms of getting impact, in terms of trying to see if there's a measured improvement in terms of people's dignity, mental well-being, etc. Is that something you're looking at actively?
Oh, yeah. Yeah, absolutely, Andy. Absolutely. It's an important factor, as Lucy and some of the other speakers brought up. Before we do any testing and before we go into any sort of test sites or user sites, we use all different types of scales and metrics to evaluate current mental health, quality of life, all different types of factors like that. We do that before and then during the implementation of our Reception, and certainly after it and stuff. And as Lucy was highlighting there, we have found that dependents that are getting quicker response times, that know that someone's going to come and take care of them as soon as possible, their moods significantly increase. you know. And if you put yourself, and you know, often developers and product developers will, if you try to put yourself in the patient's perspective and think about how isolating and lonely and uncomfortable it is, you're lying there wondering, okay, I know I've soiled myself, I'm unable to summon assistance, I'm looking at a clock now if I can to wait until I'm going to get cure. That was the traditional method. Now with reception, you know you're soiled yourself, you know the technology has alerted to that, and you know you're going to be seen to straight away, or at least as soon as possible. And I think there's a great comforting sense that goes along with that, Andy.
So we've had one question, which is, how does it actually predict? So how would air reception actually predict? Because you talked about the predictive nature of it.
Yeah, we're going into the realm of predictive analytics, machine learning, essentially. So we are creatures of habit. So it's very much one of those. When you're getting real-time data, and that's why I mentioned the real-time data. So when you're getting the real-time data as to when and where incontinence episodes are happening, you start to see patterns. And that's even us as simply, you start to see patterns in that with respect to dates, times, frequencies. And then when you feed that data through analytics programs, you can start then to predict. You can start with high probability ratio, start predicting when an event is likely to occur. So it will be one of those when the curers are aware that an event is likely to occur at this time, they can intervene before it happens. They might introduce a toileting schedule and bring the dependent into the bathroom but for those 15, 20 minutes when it's likely to occur. So that's how we're looking at promoting continence.
Interesting. Interesting. Any other questions from the audience at all? For both John and for Lucy, because I think both touched on a number of things here in terms of mental health and stress and managing depression and loneliness that I think are important. And I'd be interested to hear if we've got any input from colleagues who are on the call who've got their own input in terms of this, in terms of their own journey, their own experiences they'd like to share, or indeed to ask questions of either John or Lucy.
I know in the UK, healthcare professionals have said to me, so it's Lucy speaking, that there isn't always the obvious pathway. So bringing up mental health and especially depression and things, there are pathways, but it's complex. It's not necessarily straightforward always to get the sort of help that person might need. And perhaps that's an area to really think about. So you might be able to identify and very well understand the issues of loneliness and isolation and depression or whatever faced by someone with severe continence issues or even mild to moderate continence issues. But what you might not be able to do is find something that will help. And I do think that can be a real inhibitor to healthcare providers, especially in, you know, cash-strapped, austerity-strapped systems, not just the NHS, which is the one I know in the UK, but other ones across the globe, you know, where there is no time and money. And I think that's about making, actually what that comes down to is making better analytical, data-driven cases for intervention. So the sort of symbiotic relationship between incontinence and mental health surely means that the case should be made that investment in improving mental health amongst continence patients would pay off in the long term. But there's so much short-termism, panic, and lack of funds that those sorts of decisions are really hard to make. And they're hard in almost all healthcare conditions, let alone one that's shrouded internationally in taboo and disgust and fear and inability to articulate, and patients don't have the words and all the other stuff we know is true of incontinence. But that really does feel to me like where there is a need for the alliance between the data and the experience, and showing that there is I mean, one hates to say it, but it's the most appealing thing, right? A profitable, sustainable set of solutions that improve care and improve the, you know, how if not profitably, at least how less loss-making care can be, and this is very intensive care. You know, a lot of people who
Yeah.
have incontinence issues are people who have complex comorbidities,
Yeah.
and you know, but we also know that healthcare settings also prompt incontinence. There was research in the UK a couple of years ago that showed that women are likely to come out of hospital incontinent if they're over, I can't remember if it was 70 or 80, that going in for anything routine or like a hip replacement can result in incontinence because of the age-old methods you were talking about, John, where people were effectively put into nappies who were already continent and left incontinent. And I find those stories the most heartbreaking of all, because as you also pointed out, then the escalating social care costs of that are just, let alone the personal cost, the cost to carers, the dignity lost.
And we've seen enough on the press of examples where that's still happening.
Right.
And people aren't being offered support. They're not being offered regular checks from professionals.
And this is in what are relatively stable, relatively well-funded healthcare systems. I mean, I know someone who's doing some work in Gaza, you know, what do you do in a broken healthcare system? Or because for whatever reason, war or whatever, or what about people who are displaced? And that the costs don't go away. They eventually do come back to bite. So we have to think of ways that are long-term sustainable solutions that take the learnings we can get in areas where we've got the money and help everyone, I think, she says. I mean, I'm not a politician. So
No, I totally agree, Lucy. And, you know, there's a number of points that just jump to mind that enforce what you're saying. From our perspective, home care perspective, I believe after dementia, incontinence is one of the key driving forces that take people from their own home to
yes,
more
it's the
permanent.
second highest reason to send people into a home.
And then that's where all the costs and stuff are incurred, because it's traditionally very, very difficult for a home care provider who have their set schedule and finite window to go and deliver a cure, whether it be replace a stocking or make a cup of tea or whatever it may be. There'll be no incident of incontinence during their visit. They'll go out and close the door, and they'll walk down the road 5 minutes or drive down, and then all of a sudden an incident occurs, and that person then might not be seen again until their next scheduled visit a day or two later. So therefore, it's very taboo, and that's why these people need to go into more permanent levels of care. One of the things Connected Health is exploring is this revolutionary new approach to home care delivery, where it can have specialized incontinence teams that are just catering in real time to when incontinence care is required. And I personally believe that will be one of the facets that can help reduce the strain and the cost into healthcare. So, no, I agree with you entirely.
It was always when I used to work in care myself, it was always the key tipping point. Well, one of two. One was violence, or continence. And you know, in the system, even when I used to work in it, many years ago, it was run ragged. Literally run ragged in terms of cost, time, and the amount of pressures on the smaller, decreasing numbers of staff that were there. Those would be key decision makers, and it was usually contents.
And I think
usually
also,
it was contents.
I mean, I don't know what the research is, so I only know anecdotal things, but I think continence is actually often linked to violence. If there is sort of violence or abuse within a care or more official care setting, continence is not. What continence doesn't do is make anything easier for anyone, or lighten the load, or make anything cheaper, or make anything more fun, or less physically straining, or involve less people, or any of the pressures you might experience. And I mean, I think that's true in hospital wards, you know. And so it's a really, really difficult one, but that's what I mean. We talk about it even in these settings, but do we talk about it? Do we talk about the actual problem here, which, as you say, you know, a loss of dignity is, those three words are doing a lot of heavy punching, because when dignity is lost, that is catastrophic for everyone involved, and the impacts have reverberations. Like, I mean, crikey, some of the governments in this crazy world we live in, I mean, like, surely that even the economic case is not, it should be attractive to do something around incontinence, even if they don't give a flying monkeys for anybody's healthcare or well-being. You know, that would just be a nice knock-on. But I mean, I find it both staggering, enraging, and
Yeah.
heartbreaking at the
Well,
same
we used to always pick up on the fact that somebody who was suffering from a really, really bad UTI was much more likely to give you more than just a severe talking to, like
Yes.
a care worker. So you might get a smack if you're lucky,
Yeah.
lucky. And this is somebody who was never ever violent, ever at any other time. But the UTI triggered a completely different level of behaviour. So that used to prompt much more rapid care because we realised then that needed treating. It wasn't, somebody who's usually very, very quiet from sort of 6, 7 days a week was suddenly getting a bit ragey and quite violent. But it might be linked to that UTI that you've only just picked up on. And that was a steep learning curve, a really steep learning curve. Usually with me being on the wrong side of that curve, getting it wrong. But once you're armed with that, you kind of think, yeah, is there a UTI thing going on here? Yeah, okay. Is that being treated? How? Where are we on the graph in terms of treatment and people feeling better? Because otherwise, decisions will be made about people's care, personal care, based on non-typical behaviour.
Yeah.
And all of a sudden, relatives are put in very formal care with no real reason, and within 2, 3 weeks are back to being how they used to be, but their place is gone. They're in formal care, and you're not going to get them out again. And that's quite sad.
Don't hold me to this number, but I think from memory, I think UTIs are 22 times more likely if the dependent is incontinence.
It's something like that, definitely.
And that's not
And
to
it
mention.
stands to reason. So are other infections because,
Yeah.
you can, I mean, I talk in my book and I know I'm not alone because people have come to, fecal incontinence is so devastating that you can be somebody with, I had that when that started and I was in a senior job. I had, I had it all. I had it all. I had a house in London and 2 kids and a nice job. And I was using like cleaning products on myself because I couldn't bear how hard it was to get clean. And I was, in therapy and having lots of support. So crikey, the situation so many people are in is actually quite extreme. But I don't think it's treated with that. I mean, it is once you get to, most doctors are pretty good with fecal incontinence, but it's there's so much to say. Who'd have thought?
It's very taboo with respect to how it's being dealt with, and I think a lot of our partners and a lot of ones that we work with have different types of care environments, nursing homes and home cares and stuff, and it's very difficult for them as well because when you don't know when an event has occurred, you have to rely on these checks. These checks can quite often be needless. Sometimes it takes two carers. Sometimes it takes a house. Sometimes it takes bringing someone in and you're changing a diaper that maybe doesn't necessarily need to be changed. You'll spend your 20 minutes or so doing that, 2 members of staff, a bit of thing. They'll go out and then all of a sudden an incident will occur. So it's very, very ineffective, very costly from the labour perspective and all the different comorbidities that we mentioned. And that's not even to mention the consumables that these sites go through. I just in the consumables alone, it's 15% of a care facility's budget or thereabouts will go on incontinence consumables. And that's not even talking the treatment of the ailments such as we mentioned. And that's why digital solutions are so powerful. We have to be advocating to get those integrated as quickly and at scale. And that's why I left with the last point there. We do need to collaborate on this. There needs to be people in here that come together and say, you know what, let's look at this.
I agree, because I think even some of the innovation is when you say siloed, and I mean, most people then think of like official silos and different companies working on different solutions. But I mean, I know people working in this area, in charge of care homes for certain areas of London or certain areas of the Southeast or whatever, who have, I mean, Myra, who I quote in my talk, who's an incredible physiotherapist and has done lots of work in this area, she discovered that the ICO number for absorbency for continence pads is based on this, is the same as the ones for menstruation, so they're inaccurate. So because menstruation drips out slowly and is viscous blood, and urine is something quite different that comes out much faster. So she did she had to personally do a series of experiments to see actually how much these nappies and other diapers and all the rest of it, actually how much they held and actually who they were suitable for, because it wasn't obvious from the ICO number. And I mean, that is a level of micro siloism, isn't it? Right? That you have really good healthcare workers really, really, really trying to create the right sort of data-driven environment. But as a whole, it all fails because, you know, if you're giving someone the wrong continence device, then they and their family think that they are not coping, for example. Or if you're changing something too often or not often enough, you think that the less invasive mechanism is not working. I mean, it's just staggering, don't you think? And so I think there's so much that the data can tell us, because, you know, you're totally right. The data will show, it will start to show who leaks when, what the actual triggers are rather than what our perceived triggers are, what response times actually make the best use of everyone's time and keep everyone feeling at their best, because there will be, you know, I do think that the idea of having that sort of data-driven evidence, however stressful, it also makes me personally feel as a patient that, like, the idea of all your continence data being somewhere, I suspect the benefits can be transformative.
Yeah, definitely. I would agree with you, Lucy. And frankly, these diapers and things scare me a little bit, because people can think, okay, become over reliant on it. Okay, we've got an absorbent diaper, great, job done. No, job's not done. It may absorb an element of urine. It won't do much for any type of fecal incontinence, and that's sometimes then if there's any type of underlying perineal dermatitis or any type of a lack of skin integrity as the fecal incontinence, and they can start causing the things like the pressure ulcers, and then we get into really uncomfortable territory.
Yep.
But on top of that, then if you actually look into it, and if you talk to some of the larger nursing home and care groups, they're starting to realize that the absorbent diapers can be actually detrimental, because what they find is they're reliant on them, then they leak, then they seep, and then all of a sudden you've got linen replacements and you've got linen, and that's a heavy cost. If you're talking you've tens of thousands of beds, that can be a heavy cost. And to your point, and reverting back to a little bit on the presentation, it does nothing for the data. If we're going to mitigate these issues, we need real-time data with respect. So yeah.
Okay, well, in the absence of questions from colleagues on the call, I'm going to thank both our speakers, Lucy, for your honesty and integrity again, and talking about the lived experience, and also for you, John, to show this hope with data in ways that I think, quite frankly, are quite astounding in terms of the potential with their reception. And I wish you the best with getting that to market, getting it adopted, because that's, as we all know, in health, especially digital health, great products are great, but they're not very good if they're sat on a shelf, not being used, not being updated. And the techie in me hopes that those additional bits of additional data in terms of ambient temperature and other monitors can only grow in terms of that. So I'd like to thank both of our speakers, and for Marilyn to take the lead on this. And we will be sharing this presentation with colleagues who couldn't attend today, and other people taking part in the events of Continence Week as well. So thank you very much for both of you. And we'll press the end on the recording.
Thank you.
So thank you very much.
Thank you for having me.